I watched a health system executive spend $3 million on AI infrastructure. Loved it. State of the art, integrated beautifully. Then the CFO asked the question that nobody wanted to hear. Who pays for this? You can't separate technology from the thing that makes it work. Money. And healthcare's money is broken. Welcome back to the Clinical Realist. I'm Dr. Sarah Matt. In the last episode, we talked about the infrastructure of virtual care, the real revolution beyond video visits. And today, we're going deeper to the thing that's actually preventing that revolution from happening at scale. And we're going to use tacos. So imagine a taco. The shell is the structure. You can fill it with beautiful things: carne asada, queso fresco, cilantro, lime. But if the shell is weak, everything falls apart in your hands. Healthcare's financing model is a taco shell made of tissue paper. And it was never designed to hold what we're trying to put in it. The traditional shell, and I mean this literally, how we've structured reimbursement for 50 years, is fee-for-service. You do a thing, you bill for the thing, you get paid for the thing. Simple, elegant, completely divorced from whether the thing actually helps the patient. So a cardiac surgeon in Portland performs 400 bypass surgeries a year. A cardiac surgeon in Minneapolis performs 80. Same outcomes, same patient populations, different incentives. Fee-for-service rewards volume, not value. The shell can hold protein, veggies, cheese, salsa. It can hold anything as long as you can convince someone to order more of it. Now, here's where it gets interesting. The Institute of Medicine published Crossing the Quality Chasm way back in 2001. And we've known for 20 years. We've been trying to swap the shell. Every value-based care, new shell. You don't get paid for volume. You get paid for outcomes. You get paid for keeping patients healthy. And everyone says they want this shell. But nobody's actually building the kitchen to make it work. So what do you need to actually go from fee-for-service to value-based care? You need real data, real time, on outcomes. Not just administrative data, actual clinical outcomes. You need risk strat models that work. You need the ability to predict which patients are going to decompensate and intervene before they do. And you need clinicians trained to think differently. You need IT infrastructure to handle continuous data streams instead of episodic billing cycles. You need all of it, and you need it to work together. When I worked at Oracle Health during the Cerner acquisition, I watched these EHR platforms merging with big tech companies, the clinical data on different schemas, the billing data in different systems, the master patient index. Kind of messy. And, this is inside the same company. This is not different than any other organization in the EMR business back then. Now imagine trying to do value-based care across a fragmented market where you have 15 different EHRs, 3 different billing systems, and insurance companies that all define outcomes differently. Health systems will tell you they've implemented value-based care. That's hilarious. Basically, they're doing fee-for-service for the reimbursement, and they've bolted on some quality metrics that they report to the government. It's the same shell. They've just painted it, I guess. Real value-based care requires a fundamental reorganization of how healthcare is financed. It requires investment upfront, it requires years of infrastructure building, and it requires clinical teams to trust they'll be paid fairly during a transition period. And most importantly, it requires somebody to own the financial risk. So in traditional fee-for-service, the clinician does the work, the hospital takes a cut, the insurance company takes a cut, and whatever's left over has the risk. So usually that's the patient. So usually the patient's the one with the risk. In value-based care, someone has to say, I will take the financial risk if outcomes are worse than expected. And that someone is usually the health system. But health systems are terrified of that. So they sign value-based contracts on paper, and then they run their operations like they always have. Meanwhile, the technology industry is looking at this broken shell and thinking, we can fix it all with AI. So Vista AI just raised $295 million in Series B funding for automated MRI interpretation. Beautiful technology. But who's going to pay for it? The FDA has cleared almost 1,500 AI medical devices, but almost none of them are actually reimbursed. The technology is there. The clinical evidence is there. The financing is not. I talked about this last time, but The AMA has recently released 288 new CBT codes, first ever AI-specific codes. That's progress. But at the same time, CMS announces a 2.5% RVU cut for non-time-based services. So we're giving with one hand and taking with the other. So are we helping the taco or are we not? I don't understand what's going on here. So let me give you a concrete example of how financing breaks everything. I was brought in as a consultant to a mid-sized health system in Ohio, 8 hospitals, 120 clinics, almost 500,000 patients, and they wanted to integrate EHRs and build a unified data platform. They budgeted $8 million for the technical integration. 6 months of work. They built a unified platform. The data was flowing. And theoretically, the technical problems were solved. But then the real problems surfaced. The rev cycle didn't match. Hospital A's billing model was fee-for-service. Hospital B had capitated contracts. Hospital C was doing bundled payments. The financial incentives were pulling in 3 different directions. And when the unified platform showed that Hospital B's patients were costing less, Hospital A didn't ask why. They asked, why are we subsidizing their risk? So the technical integration was perfect. The financial integration, next to near impossible. So they paid $8 million to build a system that couldn't do what they designed it to do. The financing model broke the tech. Now, healthcare private equity deal making hit $191 billion in 2025. PE firms understand leverage. The trick, though, is do they understand healthcare financing? They're buying primary care networks, surgery centers on the assumption that they can standardize operations and cut costs. And they probably can. But healthcare financing doesn't always work like hotel chains. A PE firm that cuts 20% of administrative costs might just cut the person who understands how to contract with Medicare Advantage plans. And then suddenly you don't have revenue. So I think we're going to see kind of a bloodbath in healthcare PE over the next 3 years. But I'm willing to be wrong on that one. So I talk in my book about the rock band analogy. The lead singer is the shiny new technology. The lead singer is the shiny new technology. Vista AI, the Medicare App Store, AI guided triage. The audience is watching the lead singer. Everyone wants the lead singer to sign their latest album. But if the drummer stops playing, the whole band falls apart. And the drummer is the infrastructure. The drummer is the financing. Nobody comes to a concert to watch the drummer. But you go to a concert that doesn't have one, and it's absolute chaos. Healthcare's drummer just broke, and nobody's paying attention. Let me tell you about a case study in Uganda. So at one point in time, they had 57 different health technology pilots running at the same time, each one funded by a different donor, and most of them with no sustainability model. In facilities, you could go and they would have 3 different AI diagnostic systems running in parallel because 3 different NGOs funded them. And this not only confused clinicians, but the patient experience was even worse. And from a donor perspective, they could just see that each project worked. But if a facility has 3 different systems running in parallel because they're funded differently, does that work? And when the grant runs out, what happens? Most of them will shut down. And that's what I call pilotitis. Endless pilots that prove a concept works but never scale because there's no financing model, no way to make it sustainable. And we're doing this right now in the US with AI. Every major health system has an AI innovation lab. They work. The clinical outcomes are real. But when you ask, how do you pay for this at scale? The answer is usually, we haven't figured that out yet. Or we're doing this to see if it works and then we'll figure that one out. You see what I mean? So something that people need to understand is that the most important person in healthcare right now is the person who's looking at this, not the chief medical officer, not the COO, not the marketing team. It's a CFO. The CFO is the one asking, how do we pay for this? And if the CFO doesn't have an answer, it doesn't happen. So with the Medicare App Store, with 57 million beneficiaries eligible, is the financial model working? And I'm not joking because I feel like it's unclear. Are apps included in Medicare? Are they a separate benefit? If an app prevents an ER visit, who saves the money? So no one knows, which means the app companies don't know how much to invest. So here's what needs to happen. We need to separate the conversation about technology from the conversation about financing. We need CFOs at the table earlier. We need payers to commit to paying for outcomes. And we need health systems to stop doing pilots and start doing implementations. If you're a tech company and you don't have a plan for sustainable care, you don't have a reimbursement strategy, and you're praying for someone else to deal with that for you, you're in big trouble. So let's come back to the taco. The protein, beautiful. We have amazing clinicians. The salsa, the innovation, world class. But the shell is falling apart. Fee for service was a tissue paper shell. Value-based care is the right shell. We all know it, but we haven't built the kitchen to make it work. So here's my challenge. If you're a health system leader, talk to your CFO, not about the technology, but about the financing model. How are you going to pay for this? And if you're a CFO, ask the clinical team, what is this actually going to change? If we're spending $3 million in AI, what revenue stream increases? Or are we actually saving money somewhere? If you're a payer, ask yourself, am I incentivizing the behavior I want? Healthcare's financing model is broken. The technology is good. The clinical logic is pretty sound, but you can't separate the three. The Borderless Healthcare Revolution has a whole section on this. So how to redesign the financing model, how to align incentives, how to make value-based care work in the real world, not in theory. The taco shell is going to break. The question is, when it does, do you already have the new shell designed? Or are you scrambling to catch the pieces? So thanks for listening. Go talk to your CFO. They're the drummer, and the whole band depends on them. So I'm Dr. Sarah Matt, and this is The Clinical Realist. We'll see you next time.